So hi again. Switching gears to talk about treatment. I'm going to describe work we're doing on a novel umbilical cord blood derived cell therapy we call Duoc, which stands for Duke O-cell, which promotes remyelination in experimental models, and describe work that we're doing in treating leukodystrophies and also multiple sclerosis. And I'll just say, I really think the focus of this work is that there are a lot of patients, both with leukodystrophies and other neurodegenerative diseases out there who already have damage to the central or peripheral nervous system where demyelination has occurred. And we're hoping that this ultimately could be an adjuvant therapy that would promote repair in demyelinated areas. I'll also say that it is not, this is unique. There are lots of cell therapies that modulate inflammation, but there are not other cell therapies that promote remyelination. We got the idea to pursue this therapy because we observed in a child with Krabbe transplanted early in our research of using transplantation in kids with Krabbe. This was a symptomatic infant transplanted at 10 months of age who died of aspiration pneumonia at 20 months of age, and whose parents graciously allowed us to study her brain. And the studies we did were in collaboration with Evan Snyder, and we were able to show in the histogram here that she had engraftment of donor cells in her brain. This is XY fish on a section of cortex where she's a girl and her donor was male, and we could detect many male cells in the cortex and in fact in areas all around the brain. The green dots are Y chromosomes. And from that, we got the idea of looking at these cells, which looked mostly like microglial cells on histology. And we went back to cord blood to see if we could derive a cell from cord blood that mimicked what we were seeing in the brain. Duoc was derived from the monocytes in cord blood, the CD14 cells, and it grows in adherent cell tissue culture over 21 days. And the resulting cell, which is shown here in time-lapse photography, has the morphology of macrophages, is sticky and adherent, and expresses macrophage-like markers, including CD11b, CD45, CD14, and TREM2, which is not shown on this graph. We're also, and this is published, but we were also able to show in clinical or in preclinical models, in this case, a model called Cooperzone, which is a model where you feed mice Cooperzone. It's a copper chelator. It demyelinates the corpus callosum. And then after 5 weeks, you can remove Cooperzone from the diet and test whether you can induce remyelination of the demyelinated area prior to its spontaneous recovery, which occurs over roughly a month. So this just shows you control on the top and Duoc treated mice. It's sections of the corpus callosum, and you can see on the bottom that there's remyelination in the Duoc treated cells. The electron microscopy shows normal integrity of myelin, and on the right that there's no astrocytosis in the Duoc treated animals. We were also able to show that this remyelination was due to Duoc stimulating oligodendrocytes to proliferate, and after they proliferate, that was what induced remyelination. That's a really important concept, because if the disease causes degradation of or loss of oligodendrocyte or oligodendrocyte precursor cells, then Duoc isn't going to work. To summarize, a lot of work over really 12, 13 years now. We know that Duoc, if it's derived from a normal donor, can replace enzyme, that it also has macrophage-like activities of cleaning up debris. It does modulate inflammation by secreting IL-10, IL-6, and TGF-beta, drives oligodendrocyte proliferation, which then can promote remyelination. And on the right, we have a molecular signature that we use during manufacturing to sort of promote efficiency and isolation of the appropriate cells. Now, we've looked in Duoc and other models, including one called the experimental autoimmune encephalitis, or EAE model, where you give mice pertussis toxin intraperitoneally, and that over time induces an ascending paralysis, which is a model that people use to study multiple sclerosis. And we worked out the timing to inject Duoc intrathecally or into the fourth ventricle of these mice at the time that the ascending paralysis was starting. And we were able to show in multiple experiments that Duoc, which is shown in green and blue on the bottom, produced a cessation, I would say, of the ascending paralysis as compared to control mice on the top. The reason you see two lines for Duoc is that in our clinical trials, and I'll explain this later, we ended up modifying our formulation to include hydrocortisone. So we tested both hydrocortisone alone and Duoc with hydrocortisone in these experimental models. We've also developed models of organotypic models in tissue culture of OPCs and looked at how Duoc did or didn't affect OPC maturation. This just shows you the model of those cultures. And we were able to show that Duoc treatment in these models promoted remyelination, shown on the bottom here, after LPC induced demyelination. And having these in vitro models that don't involve animals makes it more efficient, quicker, and easier to have readouts for efficacy or mechanism of action studies. We also showed that Duoc is promoting remyelination through inducing maturation of OPCs in these cultures. And these pictures show you the OPCs as they myelinate with exposure, or as they mature with exposure to Duoc. Now, we also were interested in knowing if we needed the Duoc cells because they're difficult to manufacture, or if we could get these same effects from supernatant from Duoc cultures. So this gray bar on the right shows you the effects of the supernatant, or the factors that Duoc is producing, as compared to in the orange exposure with contact to Duoc cultures alone. So you can see that there are factors in the supernatant that are active in this setting. And we have named those RemiMax, or remyelinating factors secreted by macrophages, and are studying that as perhaps a secondary product that could be produced from the cells, but without actually administering the cells themselves intrathecally. And there are reasons why that might be easier at the end of the day for creating this product, because the cells are difficult to manufacture. They're administered fresh, and we have not figured out a way yet to cryopreserve them. So we also have shown that Duoc in Twitcher OPC cultures, so this is taking cells from the Twitcher brain, Duoc cultures also repair remyelinating activity of Twitcher OPCs. Twitcher is the Krabbe mirroring model. Now, one of our interests has always been to help kids who develop peripheral neuropathy after hematopoietic cell transplantation recover from that, or not have the nerve damage related to that. But in addition, and Maria did this work back when she was at UNC, many of these kids already have damage to the spinal cord as infants. So this shows you fiber tracking of the spinal cord in the two different children that are shown here, both with early infantile Krabbe, both with siblings who died young, both with 30 kb deletion, homozygous deletions. The little girl on the left has a pretty normal corticospinal tract at 2 days of age, and the little girl on the right already has an abnormal corticospinal tract at 2 days of age. And you can see that they have different outcomes in terms of motor disability at about 10 to 12 years of age. And this has persisted over time. So if there's damage before birth, transplant or maybe even gene therapy may not be enough to fix what already occurred if you're doing it postnatally. And again, more stimulation for correcting this another way. So we developed Duoc and a clinical trial where we were hoping to bridge the gap to engraftment in the CNS by giving a dose of Duoc to kids who were transplanted roughly a month post-transplant. And initially we manufactured Duoc from a split cord where we could use the small fraction for Duoc and the large fraction as the hematopoietic stem cell donor, meaning the child only got exposed to one donor with Duoc therapy and transplantation. We have this trial open as a phase 1 trial. The eligibility is listed here. The difference between eligibility for standard transplantation is that the Lansky, which for our clinical transplants is 60 and above, was reduced to 40 so that kids with a little more symptomatology could be enrolled on the Duoc trial. And the basic scheme was to perform the transplant and then a week or so later start manufacturing Duoc. That takes 21 days. And then we would administer Duoc 28 days later after we knew the child had been grafted, didn't have severe GVHD, and was clinically stable. We've modified this a little bit to now manufacture from a second cord blood so we can get to a higher dose and to allow Duoc administration between 28 and 42 days post-transplant. The manufacturing process is 21 days in a clean room with multiple different times that it's fed with either a standard or a proliferation media, and then harvest with trypsinization into Ringer's lactate with hydrocortisone on day 21. The stability is 4 hours. That means that from the point we take it, we harvest and do all the release testing, which includes things that take an hour to an hour and a half. We have to get it to the child who we sedate for an LP and administer before the expiry time expires. We've treated 32 patients on this protocol. We've enrolled 41, but 9 were not ultimately eligible for treatment. And we've given doses between 1 and 10 million cells. 10 million was our maximum dose allowed on the protocol. And we switched to double cord manufacturing to get a higher dose. The safety results show in the first 11 patients who all got same donor Duoc, there were no safety events. Patients 12 to 14 received second donor Duoc, and the first two out of the first 3 developed fever and hypotension on the day of infusion. It was spontaneously, it resolved spontaneously. We worked them up for infection and other things which did not occur. We tapped them 24 hours later and saw pleocytosis in the CSF in both kids with neutrophils. But again, these are kids who don't have lymphocytes at the time. We presumed it was alloimmune mediated and added hydrocortisone to the formulation. Clarified that with the FDA, got approval to do that, showed in vitro it didn't affect potency. And since we've added hydrocortisone, we've treated 24 more children or adults on our MS study without any of these types of reactions recurring. The phase 1 trial is complete, although we're still allowing enrollment as a sort of expanded access approach. The safety profile is favorable. We don't have a way to assess efficacy in these kids because they're already also getting a transplant. And so we're now testing Duoc for efficacy in a trial of adults with primary progressive multiple sclerosis in a phase 1A dose escalation clinical trial. We will enroll 20 patients. The cord blood has to match at least 4 of 6 loci. And we're testing escalating doses at 10, 25, or 50 million absolute cells. And then looking at efficacy by functional and MRI studies at 3 and 12 months. And we're also, as part of this study, looking to optimize manufacturing, see if we can cryopreserve the cells or immortalize them. And we're working on refining the potency assay, which will be required by the FDA if we ever get to phase 3 studies. Primary endpoints here are still safety. Secondary endpoints are evaluating efficacy through these functional studies and also MRI certain scales that have been developed for studying patients with MS. And the difference here between the leukodystrophy patients and the MS patients is that the MS patients are getting Duoc as a single therapy. So there's no other confounding variables around what is or is not making them better if they respond. This just shows you the flowchart of the study. And just as an update, we have 10 patients enrolled. We have 7 treated. The 8th is in manufacturing. And we're in cohort 3 for dosing, which is 25 to 50 million cells. And these are not per kilo. These are absolute doses. And to date, we have not had any safety concerns. These are adults, and some of them have had back pain or a headache for a few days after their spinal tap, but nothing that wouldn't have been expected in adult patients with this condition. So in summary, Duoc's a novel cell therapy product. It's derived from the monocyte lineage of cord blood cells. We've established manufacturing protocols for these 2 trials. And we're testing escalating doses in this trial of patients with primary progressive MS. Should this be an effective therapy, we need to optimize manufacturing in a much more sophisticated way. We know that, but it's a challenge and we're working on it. And if we can derive a product from the cultures of Duoc or this Remimax, that may be a pathway to get this into larger scale manufacturing and more testing. There are many, many people who've been involved in these trials. Some of them are called out here. The funding for the trials have come from the Marcus Foundation. We thank our patients and their families for being willing to allow us to test these therapies. So thank you very much.